Welcome to On the Edge of Breakthrough, where hope meets innovation in the fight against cancer.
Hi, I'm Dr. Monty Pal. I'm a medical oncologist at City of Hope, and I'm really excited to bring to you On the Edge of Breakthrough, Voices of Cancer Research. We're going to be bringing some of our best researchers to the table to discuss exciting findings from their laboratories, from their research programs, and really get some great perspectives on what their plans are for the future. Welcome back, everyone. You're in for a real treat. My guest today is Dr. Loretta Erhunmwunsee, who's a dear friend of mine. We kind of grew up together here at the City of Hope campus. We're going to get into the weeds today on how she's really built a phenomenal career in the area of thoracic surgery, lung cancer research, and really has this tremendous focus on disparities research that I think you're going to find fascinating. We've actually sort of come up the ranks here at the institution together for many years, and I'm thrilled to have you on the program today.
It's such a pleasure. I'm so excited.
Oh, thank you. We're going to talk all about how you transitioned from Harvard Medical School to Duke for residency to City of Hope. But before we get into that, and this is something you and I have never chatted about despite knowing each other so well for so many years. What kind of got you into the field of oncology to begin with?
So I think many different things. I certainly had an interest specifically in surgery for a while once I was in medical school. And so when there, I realized that I wanted to be in the chest most. And so that put me in sort of the thoracic surgery lane. And while training for that, I really just fell in love with the treatment of lung cancer specifically. And I just felt that it was a place where I could contribute significantly. I noted that patients and families came in scared, like just thinking that life was over. And I loved being the person who could give them hope and who could sort of walk the walk with them. And so that I think it was sort of exposure, but actually seeing the difference that I could make that made me think, yeah, this is exactly right for me.
Was this one of those things that came to you as a child? Did you know from a very young age you wanted to be a doctor? What was that like?
The truth is, early on, my family, basically, I lost my dad when I was 3. And my dad was in the sciences. He was actually pursuing his biochemistry degree. And my mom at that time was this sort of dutiful housewife and mother. And, with his death, we didn't have many resources. And so for me, growing up, we grew up in poverty. We grew up in public housing, food stamps, women, infants, and children, WIC, for those who aren't aware. And so it's for those who just can't support themselves. And so that was the experience that I had growing up. And I think in that environment, I noticed a lot of things. One, it became clear to me that family was just so very important, right? Like, I think when you don't have much, you really pay attention to what you do have, right? And I had my mom and I had my sisters, and we were, it's almost as if like we were going to win, right? And so for me, being so close to my family was so pivotal to who I became. And I was like, one, I'm supposed to help people see themselves better than their current, better than their environment. And two, I realized that I was born to like help people and serve. And because of my sort of proclivities, it was going to be in the sciences. So I think all of that, like love for family, love for community, growing up with less, but understanding that shouldn't define me in a way that I noted that it did. Multiple sort of circumstances suggested that because I was poor, because I was Black, because I was whatever, that I was supposed to be less. But I knew deep down that that wasn't right. Like, I was just like, y'all are wrong.
I feel like I have this certain kinship with you. And this is the beauty, I think, of this podcast series in the sense that I'm getting to know my colleagues on such a wonderful, deeper level. I'll share with you, my dad passed away when I was very young, 12, 13, not quite as young as you were, certainly. My mom was a waitress. And, it's so fascinating to see how that element of hardship in my life really played into my goals down the line, as it has in yours. Living in government housing, being on WIC and so forth. Do you feel that this gives you sort of a portal into the current body of research that you're doing right now? I mean, it's fascinating to me because I've seen you present on so many occasions, and there's a real expertise that you have in understanding socioeconomic variables and demographic variables. Does it derive from those original experiences?
Absolutely, Monty. And, the truth is, while matriculating through like school and training, there was sort of this declaration that certain groups always had the highest risk and death rate from almost every disease, but specifically within oncology. And I started to question how neighborhoods and how adverse social determinants might influence that because of my lived experience and understanding what my upbringing and what I lived near and what I lived without and how that might influence my own risk and the risk of others. So you're right. It is foundation for what I do. I will have to say that I am grateful for all of the success. I'm grateful for the impact that has been made. But for me, this is really like life. You know what I mean? This is like purpose, and so I'm grateful that I can promote with it. I'm grateful that I can get a grant and paper with it. But what really drives me is like wanting to make environments better for people that, you know what I mean? Like the people that I hung out with and grew up with and my people, the community that raised me, like, you know what I mean? So even if it came without a dollar or a grant or paper, I would have to do it, if that makes sense.
It makes perfect sense. I have to tell you, I remember growing up, it was never about the severity of a medical issue around deciding to go to a doctor. It was how much money you had in the bank, right? You just kind of look at how much your family has that week and you decide, do I go in to treat this cold or pneumonia or, broken ankle, right?
Right.
Yeah.
And I think, so for me in thinking about social determinants, it was just always clear that I can't, as a surgeon even, just take out the cancer and not think about the socioeconomic or the social determinants. Like it wouldn't really make sense if my patient's going back to live on the streets, right? If they're going to go back and not be able to refill their meds, then, our job is incomplete. And so that is sort of the foundation of the work that I do and that I love doing.
And I'm going to come back to this when we start diving into the details of what you're doing, because I think it bears such amazing relationship. But before we get there, I wanted to ask you about your training. I mean, you have just this incredible pedigree. Emory for undergrad, Harvard for medical school, Duke for your surgical training. Which portion of that journey had the greatest influence on where you're at today?
So I would have to admit that they all have played a important role in crafting the whole me. But certainly I think my experience at Duke, probably because it was the most difficult. I spent 10 years in surgical training, 7 years general surgery, 3 years cardiothoracic surgery. So 10 years total. It was hard emotionally. It was hard physically. It was hard spiritually. To get through that much hard training. But at the same time, it helped me become a person who could care for people in a way with excellence. And so I'm very much appreciative of it. But I think it was so impactful because like there was a turning point, right? And I realized that this was in fact what I wanted to do. And it was going to take a lot of me. And then I think is what I realized that surgery, caring for patients who are near death, caring for patients who are afraid takes a lot of you. It really does. It's not just a job. It's not just and at 5:00 I'm off. You know what I mean? And it was during that sort of training that I realized that this is what I wanted to give. And that changes you, Before we get to your time here at City of Hope, I did want to ask you a little bit about some of your work that pertains to workforce diversity, ensuring that this next generation of surgical oncologists in general, really are representative of the population. It's a hot topic these days, and I wanted to kind of get your perspectives on why you think it's so important. Yeah, no, my gosh, it's so very important. I think for multiple reasons, groups have harder barriers in getting good access to care, right? When we support the diversity of the workforce, we help narrow or lower that barrier, right? And the reason is because there's been so much data that has shown that, for instance, African-American patients who have African-American doctors do better. And the reason's because, we have a whole history of the healthcare systems doing bad to minoritized communities, like literally being a part of the problem, right? And so communities and individuals are like, you know what? I will figure this out on my own, right? Because I don't know that I can trust. And so when they are able to see someone who might have a similar lived experience, then they might be more apt to go to the doctor, go and get the surgery, go and get the cancer treatment versus being scared that the system might harm them more. We've got to acknowledge that there are barriers that kept people from getting to to being MDs or PhDs and that sort of thing. We have to understand that part of the way we get to disparity reduction is by having a workforce that's diverse, that will care more about it. We've got to be intentional about making those disparities lower so that we can get to excellence, right? Excellence doesn't happen if you have disparities. We can have all the CAR T, we can have every immunotherapeutic drug, we can have the targeted therapy. I'm in the lung cancer space. I am so glad that our outcomes from lung cancer are better and better and better. But if the disparities continue to persist, that's not excellence.
Something that you'd mentioned are the adversities that our colleagues who are minorities face, going through their training, be it based on gender, race, ethnicity, et cetera. Can you share with us how that's been impacting your career to date, or if there are instances that have really sort of shaped your career from those types of experiences?
The truth is, like, I am not like most of the other thoracic surgeons, right? I'm not like most of the other people in my biochem class. I am different. And so when there's this sort of like push to, and we do this in medicine and we do this in science, where the goal is to look like usually him, to succeed like him, to do all of it like they're doing. But I'm like, I'm not like him. So I think that sort of, so now I am very sort of happy in my skin. But when the metric of success looks like a white male and how they would do it, I'm always going to lose. I think that sort of when the standard isn't you and trying to meet it, can be exhausting.
When we met, when you were a mentee on the K-12 grant, right? And I just remember being so intrigued by the academic focus that you had, right? This association between air pollutants and the incidence of lung cancer. And, to me, I'll be totally honest with you, when I looked at this project at first glance, I just thought, gosh, this is a lot to take on, right? I mean, it's a challenging domain. It involves sort of understanding. I'm going to maybe just throw this out there, and you can correct me if I'm wrong, the physics of air pollutants, right? Understanding the biochemistry of how those air pollutants actually impact patients, right? And then understanding the epidemiology of those too, right? So there's all these nuanced elements. And then you add to that the layer of oncology, right? The treatment end of things, the diagnostic end of things. And it's a really, really challenging prospect, but you navigated that beautifully. So I want to hear more about this.
Yeah. Thank you, Monty. I can tell you that for me, it was, it's rooted in my lived experience. And, I continue to see data that suggested and shows that minoritized communities have more exposure to air pollution, specifically PM 2.5 or particulate matter 2.5. Which is a carcinogen, which is cancer causing. So air pollution causes cancer. And, people have done elegant work that shows that, for instance, African-American and Latino Hispanic communities have more exposure to this despite producing less of it, right? So Latino communities have 63% more exposure to air pollution than they create, whereas non-Hispanic white individuals have 17% less exposure than they create, right? And so for me, it was when I started hypothesizing, okay, why is it that minoritized groups have higher risk and death rate from lung cancer? I was like, okay, we need to understand how air pollution plays a part, right? And that hadn't really been done, but it was my own internal hypothesis. Like, I believe that part of the problem, for instance, with African-American communities and the higher risk of lung cancer is not smoking, because African-Americans smoke less, right? but maybe it is the neighborhoods that they're relegated to because of redlining, because of policies and laws that were intentional about disadvantaging African American communities, and that even today are still more likely to be polluted, more likely to be next to polluting factories, incinerators, and all of these things that literally push pollution, and highways push pollution into communities. And I was like, why don't we look and see if that is what's influencing this risk? And so we've done some work specifically looking at the impact of air pollution, specifically on lung cancer biology. And we found that there is a correlation between PM 2.5 and a mutation that really does lead to worse lung cancer death rates. I work very closely with health geographers and environmental epidemiologists and social epidemiologists. And so, and geneticists. And so we come together. So team science is what makes this good, right? Because it is the air pollution, but it's also the neighborhood evaluation. And as you mentioned, it is the lung cancer sort of biology and the mechanisms that link the two. There's no way that a thoracic surgeon is doing that on her own. But with this team, we're doing some really exciting work.
Tell me about the individuals that you've worked with who have been kind of pivotal in this research space.
Yeah. There's so many amazing people. I would say that, for instance, I work very closely with Marta Jakowska, who is our health geographer. She leads some of the patient-facing cores here. Vicky Seawald and Susan Newhausen have been mentors from the beginning, and they are both in the health disparity space and have sort of helped me lay the foundation of being a scientist and knowing the ins and outs of not only grant writing, but also, the scientific method. Again, in thoracic surgery, I was trained to be a surgeon, and I definitely did some research while in training, but it certainly has been my time at City of Hope where my questions were really able to be refined. And I really thank both of them for giving me time and space and support. Like, if, there were days when they were just like, Loretta, you're asking really good questions. Lorna Rodriguez is the vice chair of research in our department. And when I tell you, she is like a mama bear who's a brilliant scientist, and that combination works for me. I've had a lot of people at this institution who, again, have helped pave the way, have partnered, collaborated, but a lot of people who just encouraged me, who just were like, you got it, you're good. And then I have to shout out my thoracic surgery team, Jay Kim, Dan Rash, those are my dudes. Yeah, they hired me when I was fresh out of training, and I think they're still fans of mine. I'm certainly a fan of both of them, and they've just been phenomenal and given me time and space. They both are fantastic researchers, and so I've leaned on them for support and just guidance. And then, Yuman Fong, my chair, he's a rock star in his own right, and again, has given me space and time and support to do good things. And so it's a village. Like, all of these people have really supported me. And that has allowed me to do what I've been purposed to do. And so I take none of it for granted.
One of the papers that I really enjoy that you've written sort of takes this sort of demographic focus that you've had and actually links it to actual biology of the cancer. And that's, this paper around KRAS and lung cancer and how demographics may affect that. Can you tell us a little bit about that?
Yeah. So we looked at almost 700 lung cancer patients at City of Hope. And one of the great things that we do at City of Hope is that most of our patients undergo what's called next generation sequencing, which is basically genomic testing of tumors. And so we evaluated the tumors had already been evaluated as part of the plan for treatment. And so that is something, so these patients, their tumors were evaluated. We understood whether they should undergo, targeted therapy or immunotherapy or chemo or maybe surgery, and they were treated. But what we did was we just looked retrospectively at these 700 individuals. We looked at their genomic testing, which has already been done, and we correlated that with their census tract level neighborhood factors. One of the things that I believe strongly, Monty, is that we spend a lot of time, especially in the lung cancer space, when we usually blame cigarettes, and there's a lot of stigma. And one of the reasons why I feel like people have such worse outcomes is because people blame themselves for it, right? But we, again, want to understand how not just individual level behaviors, but how neighborhood social determinants, how neighborhood components and exposures might influence biology even, right? And so in this work, we looked at census tract level environmental factors and correlated that with the tumor biology. So being in a disadvantaged neighborhood, and that could mean a lot of different things, being in a food desert, having less green space, having less opportunities for jobs, all of that influence the biology. So sometimes we think about health disparities and we think, oh man, the problem is people can't get to the doctor. They can't get to a surgeon. They can't get to Dr. Pal, right? But that's not just it. It's not just access that is the problem with health disparities. And so these neighborhoods, right, they might not have the best hospitals, and that is a problem that we should think about and fix. But it also, they might be leading to the development of more aggressive tumors. And so KRAS in lung cancer, and probably in every cancer, when you have specific mutations, lead to worse outcomes. And we found that these KRAS mutations, which are correlated with worse survival, were also associated with the most deprived neighborhoods, right? And so again, when we think, oh, wow, poor individuals in minoritized communities have worse lung cancer outcomes, it is very likely that the neighborhoods are influencing that. And our work is trying to figure out, okay, so what within the neighborhoods are doing that? But I think that was a good foundation for us it's not just individual level problems or behaviors or exposures. It is population or community levels that is leading to some of these poor outcomes.
One of the things that I really liked about this paper, and it may not have necessarily been the intent, is that, it sort of gives us an area where we can sort of drive research focus as well. KRAS until recently has been this undruggable target, and folks like Marwan Faqih and others have started to lead these really pivotal trials looking at drugs targeting KRAS. It wouldn't be great if we could use your data and really focus on populations where KRAS alterations are enriched and really sort of drive progress using some of this epidemiologic data.
Absolutely. And I hope we are able to do that. And again, that's more team science. It's more collaboration. It's more like bringing it all together.
Yeah. No, I really appreciated that paper. That was really cool. I have just been so blown away by, a lot of the progress that you've made over the years. And one of, I'll say, my fondest moments over this past year, right, in terms of seeing, academic development of my colleagues, was when you actually were awarded the Presidential Moonshot Award. That was huge, for me, for City of Hope. I want to know what that was about and what that means to you.
The goal really is to give early stage investigators who are doing, I think in their words, pivotal science support. And so it's usually through the R mechanism. I think all of them are through the R01 mechanism, but again, it was a transition to the R37. And so the goal really is to do the work. What we're planning on doing is that work that we've done looking at air pollution and its influence on biology, and neighborhood disadvantage and its influence on biology, and understanding that the exposure to both of those are increased in certain groups, specifically in African Americans, due to redlining and due to some of the different policies that we mentioned earlier. We wanted to be able to measure these exposures sort of in a novel way. So we're going to do whole genome sequencing, which is basically looking at all of the mutations and all of the genome within tumors. And we're really excited about it because the truth is, most of the genomic work, and we understand now that tumor biology is changing the way we treat. Like, lung cancer almost means nothing now. Like it is like, okay, what is the mutation, right? Like, what's the oncogene that's driving this particular lung cancer? And so, cancer specifically within lung cancer is driven by these sort of genomic changes. And we haven't had robust evaluation, specifically in the African American community, who has the highest risk and death rate. So two different things, right? So African Americans have the highest incidence of lung cancer and have the highest death rate from lung cancer. And African Americans will develop lung cancer 5 years earlier than non-Hispanic white individuals. So each of those things are huge, right? And we don't spend a lot of time thinking about, okay, so what's driving that? And so our work is going to be looking at different components of neighborhoods: air pollution, neighborhood deprivation, residential segregation, and we're going to be looking at the whole genome of tumors. We also, again, I'm a surgeon, so the patients, and we're recruiting from throughout Georgia, throughout California, and in Detroit, so different areas in the nation. And our goal is to recruit 300 African Americans who've had stage 1 or 2 lung cancer that's been resected, right? So these are patients who've undergone resection without neoadjuvant therapy, without therapy beforehand, so we can have their tumor, do whole genome sequencing on it, and then understand how neighborhood different components influences the biology we see, the timing and the order of the mutations, and recurrence rates. So all of that would be sort of evaluated in the work. And then we have an aim that is looking at never smokers, folks, and we shouldn't call them never smokers anymore, but folks who have lung cancer who have not smoked, and looking at their sort of mutational signatures as well, and understanding how neighborhoods might influence them too. And that's really important because there was a recent Nature paper that showed beautiful data looking at 232 folks who've never smoked who got lung cancer. There were 3 different categories of mutational signature. They named them after musical terms. So forte, mezzo forte, and piano. I know you're a musician, so you know.
Oh, yes.
Right. So the mutational signatures within the piano category. So if you were a never smoker who had lung cancer and you had the piano mutational signature, you were likely to have better outcomes than forte, right? So that it was beautiful, especially never smokers. And the whole point of whole genome sequencing is to get to etiology, causality, and maybe figure out within the mutational signatures what the cause might be. Fine. So that was published and it was great. Of the 232 individuals, 2 were African American. I think 1 was Asian. When you think about lung cancer, I just told you who has the highest risk and the highest death rate. Even when you think about lung cancer and people who've never smoked, you've got to be thinking about our Asian community as well, right? So but that's part of the issue, right, Monty? It's like we have these beautiful science, but we don't center the people with the greatest burden, right? Because if I were the reviewer, I would have been like, how is it that you only have 3 minoritized individuals when we're evaluating a cancer that impacts, when we know who has the greatest burden are African American or maybe our Asian communities, right? Let's put some intentionality about making sure that this beautiful work is generalizable and will influence how we treat those with the greatest burden. So that wasn't done. So we're going to do it, right? So we're going to look at folks who've never smoked, who have lung cancer, who are minoritized. We're going to look to see whether the environment influences it and how it might influence recurrence rates as well. We're going to do it.
I was very intrigued by those papers, but I have to tell you, as somebody who dabbles, in other malignancies, I'm really kind of kidney cancer focused. This is a detail that I would have never in a million years sort of caught on to without the insight that you just provided. And that same group out of the UK has done work in my field in kidney cancer to really do a lot of what you've proposed, to look at sort of the temporal element of genes as they evolve over time, right? And a series of studies called TracerX. But, it's really, I'm going to go back to those papers and take a look and really look at the demography there and see what we can infer from that.
Monty, I think if someone's goal other than me is to get to equity, if which is simply everyone has the right to achieve their best health, everyone, no matter their race, no matter their ethnicity, no matter their socioeconomic status, if that's really our goal, then I think we've got to start centering people with the greatest burden.
The title of this podcast is On the Edge of Breakthrough. So what does that mean for you in the context of City of Hope?
This is good. On the edge of breakthrough. Well, to me, I think breakthrough and where City of Hope can shine is in really disparity reduction and elimination. And I know I know people will hear that and think, and maybe even roll their eyes and be like, okay, that's not going to happen. But I think with some intentionality, it can and should. I think with machine learning, artificial intelligence, I think with real prioritization of understanding social determinants, that we can be the forerunners in even in partnering to make that a real reality. And again, one of the things that I appreciated, and I think we both appreciate about this institution, is that it is there's space and time to bring our best to the organization. Like we are encouraged to do that. And I again feel like excellence for us includes seeing everyone, and no matter your race, ethnicity, your socioeconomic status, as valuable, and get into a place where everyone gets to achieve their best health. And that means disparities are gone. And so I think breakthrough for me, the reason I would say it's breakthrough is because there will be innovation that's needed. And I think there's a lot of us who are working towards it. I believe it can happen. This isn't a pipe dream. I think this is something that we really can achieve.
I'm going to second that. And I'll say one other key element towards this that City of Hope embarked on recently is this massive expansion.
Yes,
I remember starting here and, you could fit our whole department into a tiny little conference room. And now we've got our sites in Chicago and Atlanta and Phoenix. And there's such an opportunity there to really bring this, this equation for equity to a very diverse group of individuals around the country.
And I'm excited about that, for sure.
Loretta, this was just perfect. Thanks so much for joining me today. I learned so much about you, and I just wish you well in this amazing body of research that you're really leading from City of Hope.
Thank you so much. You're so fun. I just love being in space with you, so thank you again for the invitation.
This podcast was produced in partnership with Amaze Media Labs.